testify I'm not going to put a time limit, which some committee chairs do, but I ask that you respect the committee and respect everyone else who has signed up to testify to make sure that they have the time to express their point. And if the points that you want to make, and I know this is difficult when everybody gets a chance to sit in front of the mic and talk, if the points have already been made, if you would just say you support what has already been said, that would be very helpful. And there are several amendments that are floating around, and I'm not going to take amendments today. I am, maybe I'm chasing windmills, but I believe that there's got to be a way to work this out. And I'm going to approach it that way. If we can't work it out, then we have to decide what to do. But we've had, I think, a pretty significant, productive discussion yesterday with the Indiana State Medical Association, and after that discussion, it just made me believe maybe there's a ray of light out there someplace. And the big issue to me is that allowing an advanced practice nurse to understand that at some point in time they will not have to undergo the agreements they have with the doctors. With that, I think everyone knows what the issue is, so we'll just start with the testimony. And Heather, why don't you kick things off?
Thank you, Mr. Chairman, members of the committee. Heather Willie. I'm here today actually on a couple of different organizations to rise in support of the bill. I have seated next to me Angela Thompson, who chairs our public policy committee for the Coalition of Advanced Practice Nurses. Before I turn it over, just to make things simple for the chair's request of being brief, I would like to also rise in support for a few other organizations that I represent, one being Leading Age of Indiana, which is Indiana's nonprofit nursing homes. Mike Reinbold is here and asked that we weigh in with his support. Additionally, I'd like to also rise in support for the Indiana Council of Community Mental Health Centers. And then lastly, the Indiana Primary Healthcare Association, which I do not represent, but they were unable to be here today, and they did ask that we rise in the support of the bill on their behalf. And their board is made up of both physician and non-physician providers, and they've been talking about this over the interim and are supportive of the bill. And with that, I'll turn it over to Angie Thompson.
Good morning.
Did you sign a sheet?
Yes.
I just need, found you. Thank you.
Good. Good morning, Senator Charbonneau, Chairman, and members of the committee. I do want to thank you for granting me the opportunity to testify today, and I also want to thank the co-authors of the bill, Senator Kreider, Senator Ford, Senator Head, and Senator Becker. My name is Angie Thompson. I'm a family nurse practitioner. I have my doctorate degree, and I've been practicing in the state of Indiana as a nurse practitioner since 2009. Prior to that, I was a registered nurse here in Indiana, and I actually moved here to Indiana in 1994. So that's when I started practicing registered nursing. And as Heather indicated, I am the Coalition of Advanced Practice Nurses Legislative and Health Policy Director, and I represent that organization here today to testify in support of Senate Bill 394. The reason for the support of 394 is to remove the requirement for an APRN, or Advanced Practice Registered Nurse, to have a practice agreement with another practitioner in order to prescribe. Removal of these scope of practice restrictions is endorsed by several organizations, including the Federal Trade Commission, the National Governors Association, AARP, the American Enterprise Institute, the American Hospital Association, the National Governors Association, the National Conference of State Legislators, Robert Wood Johnson Foundation, the National Council of State Boards of Nursing, and the Heritage Foundation, to name just a few. And in 2016, the Veterans Administration, which is one of the largest integrated healthcare systems, removed the practice agreement requirement, which is in line with both the military health services as well as the Indian health services. The reason that organizations and states are moving in this direction is because practice agreements unnecessarily cause a regulatory burden and restricts access to care. APRNs are often limited to practicing in metropolitan areas, areas that are very densely populated, in order to meet this practice requirement, because as you know, there is a shortage of physicians to meet this requirement. And so it's very difficult for APRNs in the rural areas to find a physician to meet this standard. And it leaves many of our counties here in Indiana with a shortage of healthcare providers. That exacerbates that, which is why we have over 50% of our counties designated as healthcare provider shortage areas. In 2017, CAPNY commissioned a RAND analysis that demonstrated that with retiring the practice agreement, Indiana could cover more than 370,000 more Hoosiers would have access to a primary health care provider, as well as child care visits would increase by up to 32%. This is in line with national data as well. Many states have shown, and research has shown, that states that have the least restrictive practice environments have a 2.5-fold increase in healthcare access. And when you're specifically looking at Medicare beneficiaries, there's a 15-fold increase. National data from the last 2 decades, including the most recent report that was published last November by the American Enterprise Institute, showed that restrictive practices had a 40%, or restrictive states had 40% fewer APRNs compared to those without. And states that have retired their practice agreements have shown a dramatic increase in the APRN workforce. Arizona had a 52% increase. Nevada had a 33% increase. North Dakota had an 80% increase, and the largest changes occurred in their rural areas. In Indiana specifically, the RAND analysis predicted that our APRN workforce would increase by 46% in as little as 1 to 2 years with retiring the practice agreement. So I want to go into some of the misconceptions that have been thrown out in regard to retiring this practice agreement. What does that mean? And one in particular is that it doesn't jeopardize safety. The data does not show that there is any difference in the healthcare outcomes between states that have restrictive practice environments and states who do not have restrictive practice agreements. Under full practice authority, APRNs are required by their licensing state to meet educational and practice requirements for licensure, as well as national certification, and it is our duty to consult and refer to other healthcare providers based on our patients' and family needs, and we are held accountable to the public and state boards of nursing to meeting these standards of care and practice and professional conduct. Retiring the practice agreement also does not prevent collaboration among healthcare professionals or hinder any type of team-based care. The nature of healthcare and its practice is inherently collaborative, and collaboration is already a basic standard of good patient care. Communication and referrals occur between appropriate clinicians at the appropriate times based on clinical judgment, not because there is a legal mandate or a restriction on reimbursement, but because healthcare professionals are bound by professional codes of conduct to serve their patients' needs. Removal of the practice agreement also will not change the scope of practice for the advanced practice registered nurses. Senate Bill 394 only seeks to remove this regulatory barrier that hampers the ability to provide care that falls within the current APRN scope of practice. APRNs provide primary care services which oftentimes overlap as well as complement those of our physician colleagues. Indiana is facing many challenges in securing adequate health care, as we've heard a lot of testimony today about that. And during this time, it's really important that we as individual healthcare professions make it a high priority to look at ways to enhance patient health care. Some of the actions to marginalize healthcare professions, they just don't achieve the objective, and they fail the patients, who should be really our main focus right now. APRNs in the nursing community absolutely want to work in partnership with other healthcare organizations and with our other healthcare professional colleagues like physicians to address the healthcare needs. Unfortunately, with the other states who have reduced or retired restrictions, they have not been able to come to any sort of agreement with medicine in regards to what that would look like. So there is a lack of not just national support from our physician colleagues, but also within our state. So in summary, it's time to move forward with proven solutions like retiring the scope of practice agreement, and this will help us better meet our state's future healthcare needs. Understand that 22 states, as well as the District of Columbia and two U.S. Territories, allow APRNs the freedom to put their education and training to work to improve the health and the lives of their residents, and Indiana should do likewise. So on behalf of patients in Indiana and CAPNY membership, I urge you to vote in support of Senate Bill 394. And I'm open for questions.
Senator Brown.
Thank you, Mr. Chairman, and thank you very much. Appreciate all your testimony, Ms. Thompson. So you started out by saying that this restricts access to care in rural areas, and we know there's a physician shortage. I think some calculations say 1,000 physicians short by 2030 in Indiana. So how does this restrict access to care again? Are APRNs allowed to have a collaborative agreement and be working in a rural area?
They are. It's very difficult because of the shortage of physicians. It's very difficult to find a physician to meet the practice agreement requirements.
But can you have a practice agreement with a physician in a metropolitan area and you are in a satellite office in a rural area?
That's possible, but it's very difficult for the...
But that's possible now. That's not
It is possible now.
It's not
absolutely. No.
Okay.
No.
So if the concern is, and I think there is a concern about access to care in rural areas, would anyone be open to limiting this lack of collaborative agreement requirement to just those serving rural areas?
We definitely don't want to limit it to a specific site of practice. Absolutely want to make sure that we're requiring the same standards, no matter the location that an APRN is practicing at.
Well, I don't think we would change the standards. We would just allow you actually more freedom if you were committed to serving in the rural areas. So you talk about there are no differences in the results for those who don't have these, but my research has shown that the data is pretty new because they haven't been uncoupled very long. But does anyone count the near misses?
I'm not sure I'm understanding your question.
So right now you have a collaborative agreement with a physician. And so if with that oversight, whoever your partner, health provider partner is, and points out that somebody missed this, and therefore they catch it before something serious happens, those aren't counted, right? No one records that.
I'm not sure if there's a record of that. I can tell you, though, that there are over 2 decades of research that have been comparing the practices of APRNs in states that do not require a practice agreement, and the outcome data is absolutely the same as our physician colleagues.
Okay, but so they don't record. So right now, you're having oversight and a collaboration, a true partnership with doctors and DOs who are providing you that extra knowledge, maybe, expertise. No, they're not providing extra knowledge and
No,
expertise?
so I want to, if I could, maybe clarify a couple of things. So the practice agreement requirement is defined in rule. And what it is basically said, since this body allowed for APRNs to have prescriptive authority back in 1993, so 28 or so years ago, is that 5% of the prescriber's prescriptive charts would have to be reviewed retroactively by another practitioner. And that is a physician, it is an optometrist, a dentist, or a podiatrist in current statute. I would say largely it's physicians that, serve this role, but there are other instances, where those other practitioners do satisfy this requirement. So I think of it, Senator Brown, is if Angie were to see 100 patients in a week and she prescribed to 20 of them, 5% of that 20 would have to be reviewed by that practitioner. So one in 100.
Okay,
basically.
I agree.
They don't. Sorry, I didn't mean to cut you off, but they don't. To your point, there's no sort of registry of when something maybe was not prescribed correctly or a practitioner would have prescribed differently. So if that makes sense.
That's kind of my point.
Yeah.
Right? I get that. We are looking at a very small percentage. The medical community is collaborating and checking, or whatever oversight you want to call it. And that's their way of saying, okay, if I see a pattern here, if there's an issue, then I've got to go and dig deeper. My point is, though, if they do see something, there's not a place where we check. You don't lose your certification. You don't have to go before IPLA. That's something that's between you and your physician partner. That's not calculated. But that's not to say that there aren't issues in terms of being uncoupled, because no one is tracking that right now. And so for you to say that there's no difference in the data, whether you're coupled with a physician or you've been practicing on your own, is a little unfair, because no one's keeping track of the mistakes or whatever it is that the APN who's working with the physician has made. No one notes that in the chart. No one notes it in a patient's chart. Almost gave the wrong drug. Fortunately, I saw this, right? No one puts that in the note. They'd be crazy to. So my point is, I appreciate what you're trying to do here. I appreciate trying to get more care to the rural communities, but you can do that now. And you're not really asking for us to try to fix that. But what we're talking about is uncoupling you. But we have no good data to show that that the oversight isn't needed, because no one is keeping track of that. That is my point with respect to that. I just have two more questions. So with respect to if you are uncoupled, how does that work in terms of your malpractice?
Malpractice is actually required for all APRNs with prescriptive authority.
But when you leave, whatever your scope of practice, if you're working with an OBGYN, an anesthesiologist, an ophthalmologist, when you leave, will your coverage be equivalent to the scope of practice you left?
The malpractice insurance is based on where you practice at, and I would say yes.
Okay, so it's not just based on where you practice, it's based on what you do.
It's based on the risk.
Right. And so my last question is, if you are a working physician, for example, in very specialized, an ophthalmologist or a dermatologist, if you are uncoupled, will you be limited to the scope of practice in which you purport to have expertise after you leave that collaborative agreement?
Yes, we are limited to caring for and practicing in our area of specialty, or our where we're licensed and where we're certified at.
So are there APRNs who are licensed just for dermatology?
No.
Okay,
no,
so
it's based on a population. Now, certainly APRNs do get hired and are practicing in specialty practices with physicians, but there is no dermatology APRN program.
Right.
And so you would not necessarily go out and open up your own dermatology practice, because you would be practicing outside of your scope.
No, actually, because you don't have a scope. That doesn't limit you, so you could do that. Just like the letter we received from the mental health clinical nurse specialist, She talks about collaborating on issues such as sleep medicine, neurology, rheumatology, gynecology, family practice, pain management. I'm sure there's another specialty in there that I didn't read. And so there's no limitation on that.
There is. In the state of Indiana, we actually have to practice within our specialty and our certification. It is required. It was passed last year with the Senate Bill 410.
Okay, so does every specialty have a scope of practice limitation?
So,
Like I said, a dermatologist, you're gonna go out there and start telling people whether or not they have a melanoma. Are you gonna be limited to that? You feel you have an expertise?
so Senator Brown, you may recall in Senate Bill 410 last year, there was additional educational and certification requirements that this body passed and was supported in this committee to ensure that each of these population focuses that Angie's mentioned, that you receive certification in your area. So for example, if you were trained and educated to work with geriatric patients, and then you got hired for pediatric patients, you would need to go back through an accreditation for pediatrics. You could not switch from one to the other and just begin to practice, because that would be against the licensure standards and requirements we put in place in Senate Bill 410.
That's my question. Do you have the same certifications within a scope of practice of where you're practicing now, so that you can't go beyond your scope of practice? Not just where you're certified.
Yes, I guess I'm not sure. So there is no dermatology certification. So to your example, I guess I'm not certain. It's not. That's not in current statute. So it's not what is practice. I guess I don't really understand what you're looking for there.
I'm trying to make sure when you're uncoupled that you're not expanding the scope of practice where
Correct.
you purport to have an expertise. And it sounds like in some of the instances you could go beyond because you don't really have a certification right now to limit you.
No, you would need to be certified in one of the 6 population focus areas. And I can get you that bill and remind and work with you and remind you of all those requirements from last year.
Okay, thank you. Just 3 quick questions. Did you say we've had collaborative agreements since 1993?
Yes, sir. It was passed when prescriptive authority was given to 8 advanced practice nurses under Senator Miller's leadership.
Okay, 1993. Can you have a collaborative agreement if you lived in Evansville with a doctor in South Bend?
Yes.
Okay. And your review by doctors of your 5%, are they as it's going on, or is it an after the fact review?
It's retrospective.
Okay, thank you. Senator Leising?
Yeah, just a question. I know in my rural district, there's some advanced practice nurses that are doing a great job. And I'm just curious how you feel about the bill as it's drafted. It is a 1-year requirement before you're cut loose, so to speak. Do you think that is adequate? Do you think it would maybe make some folks that have angst about this feel better if that was 2 or 3 years experience? Just what's your opinion on that? Because I'm kind of mixed. I mean, I see the benefit of advanced practice nurses in my rural communities.
So Senator Leising, I know you and I had an opportunity to talk about that, and I believe it's the chair's wish that be extended at least to 3 years, which 3 years is the longest transition to practice period in the country. And we are certainly open to that and supportive of that. We have been working with, really it's been a 3-year conversation in the House, and it's newer to the Senate, but we've been working with the physician community to try to find some middle ground. At this point, we've sort of been negotiating against ourselves, if you will, but we are definitely open to 3-year transition to practice.
Do we have any idea how many states already I think I saw somewhere, it's 20-some states?
So it's 22 states, and then the District of Columbia, and then we have 2 U.S. territories that do not require a practice agreement.
And of those, do you know how many years experience they require? An average, I mean, before they're on their own, I mean, is it 1 year, 2 years?
There's only 9 that have a transition to practice. That's what that's called, that period
Transition
of time.
to practice, okay.
There's only 9, so 12 do not require that.
And those 9 that have it, do you know how many, are most of those 1 year, 2 year, 3 years, do you know?
3 years is the longest. Most is 1 or 2 years.
Okay, thank you.
Senator Breaux, did you have a question?
Yes, just a couple quick ones. So I'm reading something that says that there are 4 types of APRNs. So are you asking for all of those, the NP, the CNS, the CRNA, do we have all of those operating in Indiana, and are you asking for all of them?
3 of the 4. So in statute, yes, there are 4 types of APRNs, but CAPNY is only asking or representing the clinical nurse specialists, the certified nurse midwives, and the nurse practitioners. Those are the 3 that have prescriptive authority. CRNAs do not have prescriptive authority in the state of Indiana, so they are not included in this.
Okay, so you're asking for just those 3 to have prescriptive authority without the 5% oversight of their prescriptions and to be able to operate independently without. Now, are you interchanging collaborative agreement and scope of practice agreements? Are those the same, or are they, what's?
They're not. So in the statute, it's called a practice agreement. I think it's commonly been referred to as a collaborative agreement. And then the scope of practice is actually the types of activities that an APRN can actually perform under their licensure statute.
Okay. That makes sense. So you would want them to be able to operate independent of any kind of collaborative agreement after 1 year of operating under this agreement. And to Senator Brown's point, what would then be the oversight if, so now you're practicing without any physician review. So who then, how do we determine if there are things happening in the field that are causing, that are life affecting?
Yeah, so there are lots of checks and balances already in place. One is they're licensed by the State Board of Nursing. They're subject to accreditation, which is something that they have to have continuing education for and continued practice hours, etc. Also, if you're prescribing a controlled substance, for example, you have to go through the Board of Pharmacy to get your controlled substance registration, which is the same process that a physician would go through to receive that. If you're also prescribing a controlled substance, you would also be subject to the INSPECT program, which would be reporting, any of those, types of drugs that you would be prescribing. So I think there's a number of checks and balances for the consumer or for another practitioner that may feel that the advanced practice nurse is doing something inappropriate. There is also a process that individuals use through the Attorney General's office to file a consumer complaint, which would then be investigated by the Indiana Professional Licensing Agency and the Attorney General's office to see if someone was operating either outside the scope of their practice, inappropriately prescribing, or any of those other types of activities. And those are already all in place.
Okay, and my last question, the scope of practice, because you just said that they can practice in a number of areas. So if you are given this authority, you go put up your shingle and now you're starting to practice dermatology, or so you become a general practitioner, or how do you function if this bill passes? Are you independently going out there doing?
There is absolutely no difference as far as how we practice, but it will reduce all of the restrictions and barriers that we see in place right now. For example, for medication assistant.
How do you practice now? Then give me an example of how you practice now. So, do you have your own office and you see clients?
So me in particular, I practice at Hendricks Regional Health, so I'm employed by that facility. I am in an outpatient clinic. I actually just merged with 2 physicians. I worked in an outpatient clinic in solo practice until this past year. So I work with, as I said, 2 other physicians, and we each have our own panel of patients that we see, and I provide care throughout the day.
So is the cost for your services, if I were a consumer, is the cost less for you than it would be for the physician?
The billing is identical, but the overhead cost oftentimes is different. the overhead cost because the salary is lower and reimbursement is lower
Okay, so the
for
salary is-
Medicare and Medicaid.
Okay, thank you, sir.
Thank you. Okay, Senator Rooms.
Thank you, Mr. Chairman. Do you know how many advanced practice registered nurses have controlled substance registration? Licensed to prescribe narcotics?
I do not. I don't have that number.
Do you suspect it to be a high percentage?
I do. I can only tell you data that we collect from our own members. We do perform a practice survey every 2 years, and we just completed one a month ago, and over 95% of them prescribe. So we ask if they prescribe, not necessarily if it's limited to regular legend drugs or controlled substances.
One other question. I remember the Senate bill that last year was 410, I think you referred to. That required that advanced practice registered nurses be nationally certified.
Correct.
Or an equivalent.
Mm-hmm.
Do you know if the numbers of those that have been certified is high, low?
The number of
in compliance?
those that are certified, again, based on the practice survey that CAPNY did, is over 99% that we have in Indiana. So we do have a 1%, maybe possibly that could be a little bit lower or higher based on state, because again, that data is not collected by the state.
What is an equivalent to a national certification?
The reason why equivalency was put in the language was for those clinical nurse specialists who might be practicing in the critical care areas within a hospital setting. It would not limit them or disenfranchise them from being able to practice, because there currently is not a certification process for them, but they would in fact be able to demonstrate expertise in their field by research, as well as presenting, and there's other means of being able to demonstrate expertise in a field. So it's for that.
And finally, the Board of Nursing pretty much sets its own rules as far as your scope of practice. Is that right? I mean, aren't you under the jurisdiction and control of the Indiana Board of Nursing?
Yes.
And you pretty much set your own rules, as does pharmacy and other organizations, as far as education, requirements,
Correct.
Training, licensure, etc., right?
Correct.
So does the Indiana Board of Pharmacy then report to the professional licensing agency?
Yes. The
Okay.
Board of Nursing does, yes.
Right, all right. I just want to make sure. Thank you.
Okay, Senator Van.
Thank you, Mr. Chairman. I was just wondering, when you participate with a physician, that's like more or less a sponsorship. What are the physician's responsibilities to your actions, or where do you have the inner workings, or would you explain that situation to me, please?
I think just
what are they
as
responsible towards you, and vice versa?
I think as a colleague, I would expect the physicians that I practice with to, if they had any type of concerns, it's their obligation to report those to me, and I think vice versa.
Mm-hmm.
So I think that's just a natural relationship that you would have in any practice.
Is he responsible, say legally, if something goes wrong, if he sponsored a specific nurse or nurse practitioner?
Yes. So my guess is, for example, that if there were a practitioner, like a physician who had signed a practice agreement and something was missed in a script that they would review, my guess is if there was, litigation brought against the providers, that all of the providers would be included. But I think it's very fact specific. There's nothing in the statute that speaks to that in this bill or current statute.
Is that a factor in the physicians making a decision whether they should participate with a nurse practitioner?
I think there is some concern by some individuals, particularly if they're not familiar, they're in a rural area, for example. But I don't know that that's necessarily something that's a big issue today.
you don't think it's a big issue, and one of the reasons you only have, 5% deny. All right, thank you for the information.
Absolutely.
Okay, thank you. We're going to move on. We intentionally allowed Heather and Angela to talk a little bit longer than I'm going to let anybody else talk. Making the case, I think, for the group that's in favor of this. When we get to the opposition, I'll ask Dr. Wenck to be first and kind of lay out the concerns of the State Medical Association, and for whatever length of time she would like. But everybody else, again, we don't have a half an hour for each person to testify. I mean, it's just the way things are. So with that, I'll call on Julie Halbig to make a brief statement.
Thank you. Thank you, Mr. Chairman, members of the committee. Julie Halbig here today on behalf of the Indiana Hospital Association. IHA rises in support of phasing out the collaborative agreement and/or transition to practice. We've had many discussions internally with our members as well as with CAPNY, and I want to thank them for answering all of our questions. We would like to see the transition to practice move up to a minimum of 3 years. We do not believe a year is long enough. We also have had many discussions back and forth on, do we capture that in years or hours? But regardless, at a minimum, it needs to be full-time equivalency of that practice in the professional environment. We do feel that the additional education and accreditation requirements last year in 410 satisfied a lot of our concerns about you can't just move from specialty area to specialty area without going back and getting additional education, training, and accreditation. So many of those concerns that we had were addressed by that. I do think there were just a few additional things that we've talked with CAPNY about that perhaps we can have addressed to get this across the finish line, Mr. Chairman, as you expressed. One is either the full-time equivalency language. We also have a concern, and we are going to get more feedback from our own members, that if a practitioner or APRN would transition without a practice agreement, if the following conditions are met. One, we would like to also see the added protection to make sure that that APRN doesn't have any discipline actions against their license. And then the other thing is we're not so sure yet on where we land on a APRN getting to practice under an APRN before they phase out. At a minimum, we would recommend that probably 5 years working under that APR or that experience level be a little higher. So I'm happy to keep those discussions going, but those were some of the things that we've discussed back and forth and tried to get our questions answered.
Okay, thank you. Senator Brown.
Thank you, Mr. Chairman. Okay, quickly. Thank you, Julie. I appreciate that. So you're talking about the scope of practice. So again, trying to get this clear. If I'm a collaborative agreement with a family practitioner, I can deliver babies. The family practitioner, I can deliver babies. I can do mental health interventions. I can have an opioid treatment center going, prescribing psychotropic drugs, prescribing all these kinds of things. If I am an APRN with a collaborative agreement and I am that general practitioner and I leave the APRN and I can still do all those things, right? That's my agreement. That was my scope of practice. Am I correct in that? Because I can't seem to find anything that's limiting. The limiting is if you're in a very narrow scope of practice.
Yeah. I think, though, in the scope of practice, and I'd have to look closer at the rule for the APRNs, but, they can't be doing things that are exclusive to the scope of practice of physicians. I think there's some limitations around diagnosing, perhaps. It's my understanding they still can't do things that are outside their scope, whether we have a collaborative practice agreement or not.
I appreciate that. Everyone says that, but nobody can tell me where the scope actually ends. It seems like it's sort of like we all understand when we're in the field, and I think right now we do. My concern is we're uncoupling. We have this opioid crisis, and they're going to be able to prescribe all kinds of drugs, and no one has been able to tell me that they have to stay in this lane. And okay, so moving on, what's so secret about 1 year to 3 years? Why 3 years? Where did that number come up?
Well, so when we had our internal members discussions, I mean, let's face it, most of us in our first year were just getting up to speed and getting acquainted with the culture of our organization, our colleagues. Medicine is getting more sophisticated. So that was some of the concern of, 1 year is definitely not enough. 3 years, was kind of 3 to 4 is probably where our membership would be comfortable, especially looking at the other 9 states that have some sort of transition to practice. Again, we weren't totally comfortable with the hours and or full-time equivalency in years that most of these other states have landed on, which is just 1 or 2 years. So there's probably no magic number or good data at this point on why. It was more just based on our own experience in working in hospital teams and just knowing how our teams collaborate and work with APRNs.
Okay, well, I think that's something we need to look at going forward, particularly with respect to only 2 credit hours for pharmacology. We're just starting to get a grip around this opioid crisis, and now we're going to unleash when, frankly, in IPLA says that just last year, 500 to 600 nurses were referred for issues with drugs, drug diversion, and things like that. So I would have significant concerns. Thank you.
And Senator Brown, just one thing on your first question. I think maybe what we need to do, it sounds like, is probably look at the scope of practice and the rule for APRNs and physicians and kind of go over some of those concerns in depth to better answer that.
Thank you, Julie.
Thank you.
Appreciate it. Dr. David Crabb and Dr. Broderick Bryant.
Thank you, Senator Charbonneau, and the rest of you. I'm here with my colleague Broderick Bryant in support of the bill. My background is I'm an internist and gastroenterologist. I was the chair of the Department of Medicine and the internal medicine at the School of Medicine from 2000 to 2015. I'm the chief medical officer at Eskenazi Health now. Broderick, why don't you introduce yourself?
Senator Charbonneau and members of the committee. My name is Broderick Bryant. I sit with my colleague, Dr. David Crabb. A little bit about my background. I've been 18 years with the Department of Family Medicine. I've also served in one of the fairly qualified health centers on the near northeast side of Indianapolis, providing primary care services. Involved with resident education, also a medical director of a PA program, and also I participated with the education of nurse practitioners at our health center site as well. And serve currently in the capacity of lead provider for recruitment and also do retention for the medical group as well.
Because of the request to be brief, I'm going to summarize some of the points I'd like to make. At Eskenazi, we employ or use in collaboration with the school over 100 advanced practice providers. They work in primary care as well as very specialized areas, including our HIV clinic, the burn unit, the neonatal ICU, psychiatry, orthopedics, the intensive care unit. One of our nurse practitioners, in fact, took it on herself and created our lung cancer screening program. I collaborate with them in my role as a gastroenterologist and a liver specialist. We work well. I treat them and they treat me like any other provider in our system. Maybe the point I'd like to make best is that I don't see any benefit for the prescription review that's part of the collaborative agreement that would not be managed better in terms of quality tracking by other mechanisms which can be put in place and are in place by the employers or the practices where these individuals work. And in the information we got from CAPNY, a very small minority of nurse practitioners in the state are completely independent. So it seems to me, without knowing the specifics, they're working in groups, in practices, where there are additional oversight mechanisms that get at things beyond just did you prescribe the right medication, because that doesn't really cover things like diagnostic error, missing symptoms, and that sort of thing, which you can in other quality improvement programs that are the norm in hospitals and practices.
Also to piggyback, and I'll be brief as well, because I think some of the points and the concerns have been well made and well, I think, answered and stated. But for my particular practice, and I'll speak, I'm the chief physician executive of one of the health centers, and we do hire both physicians. We have nurse practitioners that practice in that facility. Oversight falls to the chief physician executive as far as quality of care and safety of care of that site. That is a practice activity. Provider activity is, regard to skill, competence, and development of those skills and competencies. But as far as the safety of practice and quality of care that's delivered in that practice, that is oversight, and directly my oversight at the practice. And what Dave is speaking to is that at Eskenazi Health, or in our facility, we do have those oversight measures. So when you talk about safety of practice and quality of practice, we have protective mechanisms there that also provide those services.
Thank you. No questions. Did a great job. Thank you. Blaine Miley. Blaine, this is your second time up, so we're...
Thank you, Mr. Chairman, and I will be brief and just address some of the questions that have arisen so far. With respect to the regulation of APRNs and really any nurse with regards to staying in their lane with regards to scope of practice, the way that the Nurse Practice Act is written in the rules is that there are general standards, the most relevant being that any nurse of any level must only perform services for which that nurse is prepared by education and experience. Now, the Board of Nursing does not set out, okay, if you are this type of nurse, then here's a list of the procedures you can perform and here's a list of the procedures you cannot perform, because they are going to view each disciplinary case that comes before them on an individual basis, because even within a certain classification of nurse, there's going to be variability in what that nurse is trained to safely provide to their patients. With respect to catching near misses, if near misses were providing demonstrable material benefits to patient outcomes, then the patient outcomes data in states without the collaboration requirement would be worse, but that is not the case. There is a requirement in the rule that a APRN must maintain geographic proximity with their collaborator, but maintain geographic proximity is not defined. With regards to liability, there are 2 Indiana Court of Appeals cases on the liability of collaborating physicians with APRNs. Harper versus Hippensteel held that unless the collaborating practitioner takes an affirmative action to establish a provider-patient relationship with the patient of an APRN, then that collaborating practitioner cannot be sued for medical malpractice based on the actions of the APRN. The second case is Collett versus Ratz, which says that there is a general tort obligation of the collaborating physician or practitioner to perform their collaboration duties such that a collaborating practitioner could be sued under a general negligence action outside of medical malpractice based on a alleged violation of that duty. And a reminder of the numbers of the nursing profession when we talk about any mention of nurses referred for disciplinary action. If it's 500, then that is nurses of all levels and would be 0.4% of our licensed nurses. With that, I'll be happy to take any questions.
Thank you, Blaine. No questions. Mary Browning.
Thank you, Senator Charbonneau. IONE, again, represents nurse leaders throughout the state, and we are committed, as I know this committee is, to providing care and access for patients. And we feel very strongly that removing the collaborative practice agreement will help increase access to our patients throughout the state. Thank you.
Thank you, Senator Brown.
Thank you, Mr. Chairman. I'm sorry, what organization do you represent? I didn't understand that.
The Indiana Organization of Nurse Executives,
Nurse
leaders throughout the state.
So is there, if we're interested in increasing access to care, my understanding is the advanced practice nurses can practice independently, they just don't have prescriptive authority if they practice independently. Is that correct?
No, well, if they haven't achieved prescriptive authority, but if they have prescriptive authority and practice in other parts of the state, as Ms. Thompson explained, the difficulty with collaborative practice agreements is when we have nurses that can practice in outlying counties and there is not access to a physician to be part of their collaborative practice. And so they have difficulty finding physicians who will agree to be their collaborators.
Okay, so, but there's nothing in the current law that prevents that. Is the concern that a physician doesn't really want to oversee someone when they don't have eyes and ears on them?
Yes.
And so they're not comfortable collaborating with an advanced practice nurse who's not close to them, without eyes and ears on them, because they're not really sure what they're doing and they're linked to them. But this bill would uncouple them. So that makes me give pause if a physician is not as likely to collaborate with someone who doesn't have very close proximity. But this bill would not only uncouple them and allow them to practice with full prescriptive authority.
True, but after...
Without any, and so I'm sorry to interrupt, in the current bill, without any hesitation. In terms of years out?
No, in the current bill, there's the requirement once the nurse becomes an advanced practice nurse that they have the 1 year.
Well, 1 year.
1 year, and then the discussion has gone to 2 or 3 years, which
right.
I understand we'll have further information on that. And I think that that oversight is sufficient, and the 5% chart review collaborative practice is not really necessary as we move forward.
Thank you.
Thank you. Amber?
Thank you, Mr. Chairman. Do you mind? I have some information that I wanted to provide that has not been provided to.
Okay.
I'll do that after I'm finished. So thank you, Mr. Chairman, members of the committee. I will be very brief. Amber Marr with AARP Indiana, with approximately 835,000 members statewide. We appreciate the opportunity to rise and support. We do agree with everything that has already been said. So the only thing I wanted to point out, as many of you have heard me say before, we stand up here on behalf of family caregivers as they are the front line of our healthcare system for many older Hoosiers. They are providing care that is valued at $9.5 billion annually, and it's because of their efforts that their loved ones are getting to stay in their homes and communities where they want to be. So very quickly, what I will be handing out is Senate Bill 394 removes those bureaucratic red tape that can prevent APRNs from serving as primary care providers and working to the full extent of their license. A survey of Hoosier voters age 45 and older conducted by AARP in 2018 showed that 86% support allowing APRNs to serve as a primary or acute care provider of record for a patient. So I will make sure you have that information, but we wanted to provide the consumer patient voice today. We appreciate that you brought this bill forward and that you gave it a hearing, and we appreciate Senator Kreider and Senator Ford for signing on. Thank you.
Thank you, Amber. Questions? Last name Morrell. First name, I think it's Ty.
My name is Ty Morrell, and I'm a family nurse practitioner in Rush County. I would like to thank all of you for allowing me the opportunity to speak today. I work in a small private practice with my father, Dr. Douglas Morrell, within my community. I am also the current Rush County Board of Health chairperson, and I provide care to inmates at our local jail when my father is out of town. With the way the current Indiana law stands, if my father, who is now 70 years old, were to retire, or even worse, pass away, I would not be able to practice without paying a substantial fee to a physician to sign off on 5% of my charts. There would not be a provider to serve our local jail, and a large percentage of our community's population would be without a primary care provider. To further expand on Rush County's shortage of physicians, this past August, our local health officer resigned. The Indiana State Department of Health recommends 2 physicians to serve on each county's local board of health, along with 1 other physician, who is an MD or DO, to serve as health officer. It is recommended that the physician live and or work within the county that they serve. Our board was unable to previously fulfill the 3 physicians needed. For 10 days, Rush County did not have a health officer. We were unable to move dead bodies across county lines, no one was available to sign death certificates, and no one was able to sign food or septic permits. Our community was literally at a standstill. As health board chair, the only 2 physicians I had to choose from who live within Rush County were my father and 1 other physician, neither of which were willing to take on the position as our local health officer. After 5 months of having a temporary health officer, we were finally able to get a physician who does not live within Rush County to fill in as our current health officer. We are still short on having 1 other physician serve on our local board of health. Physicians are not moving to rural Indiana. Compared to many counties in southern Indiana, Rush County really is not that remote. Rush County is less than 1 hour from where I am sitting today. And yet, it has been incredibly difficult for me to find physicians to serve as our health officer and be on our local board of health. Over 23,000 advanced practice registered nurses graduated in the U.S. between 2016 to 2017. By contrast, 3,535 U.S. medical school graduates were matched to primary care residency programs in 2018. 87% of APRNs are trained in primary care. We are able to fulfill the primary health care provider shortage that rural communities in Indiana face. My point here today is to simply highlight the shortage of physicians we have in rural Indiana. Allowing APRNs to have full practice authority does not interfere with interprofessional collaboration or team-based care. In states where APRNs have full practice authority, more patients have access to primary health care providers. Thank you for allowing me the time to speak today.
Thank you, Ty. Senator Brown.
Chairman, thank you very much. Appreciate your testimony. Do you think that the county health officer should be an MD or DO?
Not necessarily. I've been on the board for 6 years, and I've gone to more, the Indiana Department of Health puts on a meeting every 6 months, and I've gone to those, and during that time, the person who temporarily, or who actually filled in, I've gone to more of those meetings than what they have, and I probably talk with David Hopper and the actual commissioner more than what he does. So I think I'm more involved than what our current physician is.
Okay, well, I appreciate that. I'd have to say I'm glad that our Allen County health officer is a medical doctor. But anyway, besides that, nothing in this bill we're discussing today would change we're not creating any more doctors with this bill, and there's nothing that would allow you to substitute yourself.
Correct. But my point
the medical health officer of your
correct.
County. Okay, I just wanted to make sure.
My point is simply that it has been extremely difficult for me to find 3 physicians to fill in on our local board of health within our community, and we're only an hour from Indianapolis, but we have a huge primary health care provider shortage within our community.
And perhaps it's just participating on yet another board, which has nothing to do with access, but thank you.
Senator Lysing. What?
Yep,
Ma'am.
Ty.
Ty.
Thank you for coming from Rushville today and kind of reinforcing what I keep telling these guys about our rural counties. You know how short we are of physicians, even of hospital services. You know, your county is one of the counties that you can't have a baby of.
Correct.
Of my 7 counties, 3 of my counties, you cannot deliver a child, you know. And if you just go over into Senator Rotz's district, there's more of those. So I think, you know, there's some areas that are really deficient in healthcare, and a lot of times when people are in Indianapolis and the hospital's on top of each other, it's hard for them to understand that. How long have you actually practiced as in your role now with your dad?
So I've been with my father in his practice for 3 years, and then I practiced 3 years prior to joining him.
Okay. And I mean, this whole debate about the necessary experience, hopefully if this bill moves forward, I mean, having had the experience you have now and the experience you've had practicing with your dad and recognizing that at some point your dad may have to retire, age out, whatever. What's the appropriate number of years, do you think, for experience? I mean, do you think that that's
So
pretty
our
important?
background's different. We're population focused, but some of my classmates that I went to graduate school with had 20 years of experience. So if they're a nurse with like 20 years of experience in the ICU and they go on to be an acute care nurse practitioner, do they necessarily need 3 years to start out if they've had all of that experience?
So it kind of depends on their past experience in total.
Correct.
Got it. Okay. Thank you for coming. Appreciate it.
Thank you. Robin Newhouse. And then Kristen and Dee Swanson.
Hi, I'm Robin Newhouse, Distinguished Professor and Dean of Indiana University School of Nursing, but I'm not speaking in that capacity. I'm speaking for myself as a private citizen concerned about the health of Hoosiers and as a scientist that does some of the original work about the comparative effectiveness, safety, and quality of advanced practice registered nurses, and I'd like to leave some of the data that I'll talk briefly about. So let me just start by saying I've heard a lot of questions about who advanced practice nurses are, so I just want to be clear that we're talking about a role, so a nurse practitioner or certified nurse midwife. We're talking about a population, so a neonatal nurse practitioner or a pediatric nurse practitioner or a psychiatric mental health nurse practitioner. We're talking about people that have come into a graduate or a postgraduate program with most of the time years of experience. So about half of the people have more than 11 years of experience, and about 80% more than 6 years of experience when they enter the program. So we're talking about people with a clinical degree and a license. When they graduate from the advanced practice program, they will be certified and they will have a practice arena that's associated with their training. So as opposed to a physician where they get the whole continuum, where they go to surgery and they are going to do a rotation in pathology and a number of other things, the advanced practice nurse already has a number of years of clinical experience, has already had a clinical degree, is already practicing, and comes into an advanced practice program where they add additional training in diagnostic reasoning and prescriptive authority, for example. So they have a very narrow scope of practice. That being said, years ago, we were funded to conduct a study of the comparative effectiveness of advanced practice registered nurses. And I'll provide you with that data. And without going into it, the studies are clear. That question is answered. This debate is not about quality, safety, and effectiveness of advanced practice nurses. And in addition, the additional study that was mentioned earlier, the American Enterprise Institute, I just want to mention two additional things. That's our study went through the comparative effectiveness of randomized trials and observational studies from 2000 to 2008. The American Enterprise Institute was issued last year, which actually provided data and some of the quality metrics after the change, and there were increased states that had adopted no collaborative agreement, so full practice authority, essentially. And so I won't go any farther into that, but one thing that I want to make sure I mention is the cost associated with advanced practice care was lower, about 11% to 29%. And when we talk about the rural environment, and compared to primary care physicians, primary care nurse practitioners that their setting is primary care, not acute care. Despite there are less nurse practitioners, they are more likely to practice in the rural areas than primary care. So that's a good signal, I think, for us when we think about the reduction of this collaborative agreement. So I will stop there. There certainly are other studies that have been conducted. They are fully available in the materials that I'm giving to you. There are some studies that Cochrane has published that are global studies that aren't really comparative, that have evaluated the substitution of nurses for physicians, but it was really registered nurses and advanced practice nurses, and it was 6 countries, including South America, Spain, and others. So I'm not talking about those studies. I'm talking about studies that were conducted here in the United States, and I'd like to provide you with the data.
Thank you, Doctor. Appreciate your one question here.
Oh,
Senator
certainly.
Brown.
Thank you, Mr. Chairman. Thank you very much for your testimony. So, previous speaker talked about 20 years. You mentioned 6 years. That's before they go into the APRN program. So, is there any requirement to have clinical practice and experience before they become an APRN?
Well, they get clinical practice that is supervised and
but
during the program. But is there a residency, like a post-residency?
So I can graduate with my RN, BSN. Can I go right into an APRN program?
Some yes, and some no.
Okay, but assuming my grades, et cetera, board score, whatever, I can matriculate that quickly through the program.
Some yes and some no.
Okay.
But what I would say is very often our advanced practice registered nurses go to school part-time, so it may take 5 years. So they actually are practicing while they are in school. So there's additional practice as a registered nurse.
No,
Others
I
take about 3 years.
appreciate that. We've heard all, I know people with 20, and you said most of them have had 6 years of clinical experience. But there's nothing in this bill that requires that. There's nothing in the bill right now that requires clinical experience. They could literally matriculate right from college or their RN to an APRN and be practicing, if this bill went through, after 1 year collaborative agreement. So they would be out in the workforce, so to speak, for 1 year after their education. No other experience. So would you be considered putting in clinical training years as well to this besides the collaborative agreement years?
Yeah, I think I would like to see the data about that, number one, if we have it. Number two, I would say that there is data related to the quality metrics of each provider when they're reimbursed by Medicare or Medicaid. So I don't have the data. Would I feel comfortable? I would feel comfortable going to somebody with a year of practice as an advanced practice nurse. But I think that is one of the considerations that we should debate.
Right. That's not, I appreciate that, but the metrics don't really help because those are longstanding collaborative agreements. We don't have anybody testing APRNs who are 1 year practice to show what the data looks like, but we're going to take that leap off the cliff with this bill with no clinical experience. So that would give me pause, but thank you. I appreciate
Senator Breaux.
Quick question. So APRNs, they have a minimum of a Bachelor of Science in Nursing, correct?
They absolutely do in our program, yes.
Okay. And then the certification of the APRN, that is in addition to the BSN?
Yes, it is.
So is it a master's level or?
Some programs are master's level and some programs are doctoral level. So many of the advanced practice registered nurse programs are transitioning to a doctoral level.
Okay.
It's a terminal degree.
And then my last question, I'm just trying to keep all this straight. There are no special, APRNs do not specialize in a particular area. They can or they don't have to. They can run the full spectrum of either or.
Well, they are educated in a very narrow scope.
Okay.
So neonatal,
So there is
pediatric, family nurse practitioner.
That's what I heard you say.
And a population, psych mental health I should have mentioned because that's very important in the state right now.
Yes.
But if there are specific specialties they'll be trained in, their clinical setting usually will conduct the training. So there, endoscopy, for example, it's sort of a broad, they have a scope of practice for the population in the setting. But when you get very specific in a specialty, they need some deeper training in that specialty.
Okay.
And the clinical setting usually assists with that.
Okay.
Senator Kreider.
Thank you for your testimony. And so part of the certification process is clinical experience where you're working under, let's say it's a family practice NP, working under the supervision of a doctor in an office setting. And that doctor then would sign off that you demonstrated sufficient skills to be certified. Is that typically the situation?
They're in a number of settings because they have to have interaction with multiple kinds of patients. They document the patients that they do see, and yes, there is an evaluation by their supervising provider.
Can you estimate how many hours that potentially could involve?
The hours for an advanced practice nurse range between 500 and 1,000, so it varies on the population and the setting type, and all are national standards, for example.
So if somebody took the particular track that Senator Brown mentioned and simply went through the steps, in my experience working in healthcare settings, that's not the situation, but they simply went through the bachelor degree and then went on to NP. Over that total experience, their hours of clinical experience would number into several thousands?
Oh yes. I mean, because they have a lot of clinical experience where they have made critical decisions working with patients. A patient interaction and a difficult patient interaction is not unusual for a registered nurse. So they've had that experience. Now they're adding an additional layer of diagnostic reasoning and prescriptive authority onto their current license.
Thank you.
Thank you. Before we go any farther, is the little guy in the peach shirt over there going to testify? Are you for or against? Okay, so when we get into the opposed, I'll move you up. He's been absolutely fantastic. I've been watching him the whole time. So we just have two more, Kristen Lais.
Oh my gosh, you did it. You got it. Hi, Kristen Lais with the Area Agencies on Aging. Good morning, everybody. It's still morning. Thanks for hearing this bill and for the opportunity to testify and support. In general, area agencies on aging have an interest in assuring good, fulsome access to primary care, especially in rural areas. In our roles, providing care transitions from hospital to home, from nursing facility to home, one of the steps in that process is assuring linkage back to the medical home, the primary care provider. And that impacts the readmission rate, which is to hospital or nursing facilities. So that availability of that primary care provider is critical in ensuring that we keep costs down for Medicaid, for Medicare, and for healthcare payers in general. So it's critically important to home and community-based services and ensuring people can stay in their communities instead of having to move to larger areas where there's more healthcare access, or to facility-based care where there might be additional provider access. Thank you.
Thank you. Dee Swanson.
Thank you, Chairman, members. I am a nurse practitioner, family nurse practitioner, have been for 26 years. I had a lot to share with you, but most of it has been covered, so I'm going to address three things. Number one, scope of practice. Right now I am a family nurse practitioner. When I went through my original master's degree program, I was an adult nurse practitioner. I ended up in a setting where I needed to see children, so I went back to school to Northern Kentucky University for 2 years to obtain the qualifications to become certified as a family nurse practitioner. I've obtained additional education depending on my interest in scope, wanting to learn more, of course. What we learn in school evolves over time. What your scope is initially changes with time, practice, technology. The second issue I would like to bring up with you is the one of controlled substances. I have a DEA license and I have for 20 years. Every month I get a list from my system that tells me all of the patients I have that are on controlled substances. To be able to prescribe a controlled substance, I have to electronically transmit prescriptions that limit me in what I can prescribe unless I provide a reason to exceed that amount, like a hospice patient or something like that. So there are controls and there are mechanisms that are coming into place to control that. And people don't typically willy-nilly prescribe opioids to patients. They generally have to have a reason, meet criteria, and that's not somebody who's sprained an ankle, okay? The third thing I want to bring up to you is access. I practice in Brown County, which is a rural county. There is no hospital in Brown County. I work for Indiana University Health Southern Indiana Physicians Group. There are 2 nurse practitioners in my practice and 1 physician. I have been in the practice for 15 years. In that time, I have lost 2 collaborative physicians and had to find someone else to help so we could keep the clinic open. I had to find a physician in Gosport. Both times I lost a physician. That physician is now in his 70s, and I might not be able to find another person if the current physician leaves the practice. I have a panel of patients. I'm credentialed as a primary medical provider by Medicaid. I can have a panel of 500 patients. I provide high quality care. We're not talking about anything here today except access, and that is what we need. Not everyone accepts Medicaid either. There are a lot of people in the state who have no provider who will accept Medicaid, so that's another population to consider. Thank you.
Thank you. One question.
Yes, just real quick. In Brown County, prenatal services, who provides?
Family practice does, but most of the time people will go to their OB. In fact, when I see an OB patient, usually I tell them you're pregnant, don't do drugs, get started on prenatal, we're getting you an appointment to OB.
And they have to go where? Do they have to go out of county?
In my area, they can go to Columbus, they can go to Franklin, they can go to Greenwood, they can go to Bloomington, they can go to Morrisville, they can go to Martin, or Seymour or Bedford. I have a large pack.
Okay, thank you.
Thank you. Okay, we're now going to flip to the those in opposition. And as I said, we're going to start with Dr. Wink. Now, I think it's, as we did with the supporters, I want you to kind of lay out the issues that we're dealing with, and then we will move to the young man over on against the wall. And again, we have to be done by noon. I just ask that everybody be respectful of time. Thank you for being here.
Thank you, Chairman Charbonneau and members of the committee. First of all, when I look at that little boy, I see my 22-year-old. Secondly, I'm Italian, but I did promise you that I would keep this short, so I promise you that I will. I'm Dr. Stacy Wink. I'm president of the Indiana State Medical Association. I am testifying on behalf of over 8,000 Indiana physicians in opposition to Senate Bill 394 as introduced. I also represent the Indiana Osteopathic Association on behalf of their 1,200 Indiana physician members. Let me begin by acknowledging the vital role that advanced practice registered nurses bring to the healthcare team. I've personally worked with several APRNs and recognize the value that they bring to the table. I will also share that I work collaboratively and side by side with my nurse practitioners. I review and discuss cases daily with all cases of patients that we're managing together. The ISMA is not opposed to APRNs, but supports physician-led team-based care. Thanks to the extensive education and training, physicians have a vast knowledge to identify complex issues that may arise and provide patients access to this knowledge through physician-led team care. This preference is backed up by a patient opinion obtained in a survey by the AMA, where 91% of respondents said that a physician's years of education and training are vital to optimal care, especially in the event of a complication or a medical emergency. Senate Bill 394 would also allow an APRN to practice independently after 1 year of collaboration. In addition, the bill would allow an APRN to collaborate with another APRN. Due to the fundamental difference in education and clinical hours that new physicians experience versus that of the APRN training, we cannot support Senate Bill 394 as introduced. A summary of the process of physicians completing their training and education prior to practicing independently includes 4 years of medical school. During that time, there's classroom work and clinical rotations in a variety of settings, which has been previously shared. After these 4 years, physicians then go on to complete a residency, which provides advanced specialty training. And this lasts between 3 to 8 years in that specialty. Residencies have clinical hours that are structured, graded, and have direct oversight by an experienced physician at all times. Throughout medical school and residencies, physicians complete a 3-part exam, and at the conclusion of residency, physicians then sit for an exam within the specialty of their residency. At the completion of this process, new physicians experience 10 to 15,000 hours of directly supervised clinical training. Personally, as a new physician many years ago, I still felt the need to collaborate with my more experienced peers on some medical care needs. In contrast, the education process for APRNs include registered nurses who complete an additional graduate degree in preparation for practice. These degrees are typically a master's degree for nearly 90% of the APRNs. At this time, only approximately 6% of APRNs hold a doctorate level degree. The master's program has classroom work and clinical hours. However, the clinical hours require a minimum of 500 hours. This is similar to the exposure of medical students. With these fundamental differences in mind, the ISMAs opposed Senate Bill 394 as introduced. We do not believe a medical student has the experience needed to practice independently, nor do we believe 1 year of collaboration is adequate for APRNs. We believe that a physician's involvement through true collaboration provides patients the connections to advanced knowledge and experience that is necessary for comprehensive, safe patient care, particularly when complex issues or emergencies are encountered. Should the legislator decide to advance the bill, we would suggest that an APRN complete a much larger amount of clinical hours with direct collaboration with a physician to ensure they have the opportunity to gain knowledge in a meaningful, collaborative environment. I just want to clarify that Virginia has a requirement of 5 years prior to independent practice. In addition, APRNs have full prescriptive authority, yet there are no requirements at the Board of Nursing to include members that have full prescriptive authority. Therefore, we believe the Medical Licensing Board should have input into the regulation and oversight of independent APRNs to standardize these regulations. At this time, we would respectfully request that this bill be held. We've met with the author, and we would like to be a part of continued discussions about ways to ensure high-quality, safe patient care should the committee decide to move this bill forward. Thank you for your consideration of my comments.
Thank you, Dr. Wenk, and I appreciate your brevity and to-the-point presentation. Senator Lyson.
Yeah, just one question, Doctor. Have you yourself had the opportunity to work with an advanced practice nurse?
I've worked with dozens of APRNs. I have been in practice for 25 years.
And you have worked with advanced practice nurses. And,
yes.
and under the present law, what do you see when you've worked with them that you've provided that if they were independent, it's not going to be there?
Sure. I've had direct oversight. So we discuss cases real time. And so I review their charts daily. I review all charts. So I'm not only looking for the required prescriptive 5% chart review, I'm doing 100% chart reviews so that I have a chance to sit down and give them additional knowledge, education, and experiences.
But Under the current law, 100% is not required, right?
And that's why we talk
And
about.
it's only 5%?
Of prescriptive. And that's why we're talking about, prior to independent practice evolving and developing, a better collaborative arrangement and agreement so that we can provide the training so that there are opportunities.
Okay, thank you.
Thank you, Doctor. Oh, I'm sorry, Senator Breaux.
Did I hear you say you would like to have the medical licensing board have oversight of APRNs?
I'd like to see. I'd like to see anybody with prescriptive authority fall under the medical licensing board. Now, whether there's a collaboration, many states do a collaboration between the medical licensing board and the nursing boards. But at this point, there isn't any oversight from the medical licensing
community. Okay.
Senator Brown.
Thank you, Mr. Chairman. Quick questions. Did I hear you say that if we go to this uncoupling, you would like to see the physician collaborator have more oversight, more than 5%, before we unleash these APRNs into the population to practice on their own?
Yes.
Thank you.
Now, your name, please?
We are Tana and Teddy Boyer. We live in Zionsville. I come to you as a practicing physician anesthesiologist at Riley Hospital for Children. Well, it's good. We're good with germs. Germs are good. I do not speak on behalf of my employer. I am a member of the Physicians for Patient Protection, which is the national organization fighting against scope of practice for mid-level providers. So I just want to emphasize to you the educational differences that our med students have at IU versus the APRNs that we're hearing today. A med student at IU will have completed 500 hours in about 3 months, maybe 4 at the most. They will go on to complete their 3rd year of medical school, their 4th year of medical school. They will take 3 licensing boards that are written by the NBME and vetted. They will then apply for residency and do 3 to 7 years, possibly a fellowship. After that, they will take board examinations in their specialty area. So I am board certified from the American Board of Anesthesiology. I would never think to leave and go practice family practice, even though I've completed medical school. I would not practice as an OB-GYN. I would stick with my medical specialty, which is anesthesiology. I think the further I practice, so I'm 5 years out of fellowship, the more I practice in the field of pediatric anesthesiology, I do not feel that I am up to date on adult anesthesiology and the practice of anesthesiology in critical care units and that sort of thing. So I'm opposed to this bill as it's written. There was a point in history in the 90s where the NBME, that writes the physician licensing boards, also wrote an NP exam. It was administered, it was failed at alarming rates, and it was abandoned. There's no evidence in the states that have full practice authority that we have actually expanded care. There's maps available from the AMA that will show you people tend to, he found a button, people tend to practice in cities where they live, and that includes all providers, not just physicians. There's some papers that show increased cost associated with advanced practice nurses. Because of the lack of training, they are referring out more, and they're also ordering more radiographic studies. There are no standards and guidelines on those 500 hours. It's just a number of hours that you have to shadow. Even if you say it's 1,000, there's still no guidelines. There's a lot of ways that I see that you can fix access to rural care in Indiana. So GME funding has been capped since the 1990s at a federal level. There are some states, such as California, that have decided to pay for more graduate medical education funding, specifically in primary care. There are programs that IU is trying to start and expand. There are programs that IU is trying to expand at the branch campuses where we have the medical students that will have family practice, internal medicine, and ER residencies. So that growth is possible and an option. So I will leave it at that since we're fighting for the microphone.
Thank you. I think you're losing right now. Thank you very much.
Thank you.
Appreciate your
questions?
patience. No. Raghu Modaganahali.
Good morning, everyone.
Good morning.
Dear Chairman and respected members, thank you for giving me this opportunity to be here as well as speak a little bit about the current bill in its form. I'm a vascular surgeon. I practice at Methodist Hospital. I'm an associate professor, the program director for vascular surgery, as well as the division chief. I represent American College of Surgery. The views expressed by me are purely through the college, not through my employer. I'm here complementing the role of our APRNs. APRNs fulfill a significant role in the delivery of our healthcare. They do take part in a team-based healthcare delivery system as it exists now. However, taking away this oversight as well as the medical expertise as well as the physician supervision that comes along with that would mean we will place a lot of patients at risk of having duplication in their investigations, more referrals as earlier pointed out, and clearly it will at some point in time may lower the standard of care what is being delivered to our patients. It will certainly take away the factor of collaboration. We did discuss about that earlier, and that will become a problem as we move forward with this bill in the current format. I would also like to bring in the key differences between the medical school as well as the APRN. We have discussed about it, but briefly I would like to emphasize that medical education is more or less a standardized affair. Unlike there is a significant variation within the APRN training that does vary from state to state, as well as it varies from the structure what they're practicing with. On an average, I would say after the medical school, one would spend about 10,000 hours getting into the residency and getting through the residency program. In a situation like mine, to become a vascular surgeon, it does take about almost twice or thrice the number of that hours to even attain the professional competency as well as to make sure that we attain the utmost rigor delivered in the training program. However, according to the Institute of Medicine Future of Nursing report, APRNs need only about 500 to 720 total patient hours through their training program compared to exhaustive and training programs what is offered to the physicians. The American College of Surgery does have 80,000 members across the globe, and we represent one of the largest surgical organizations in the world, and there is about 1,100 members from the state of Indiana. The American College of Surgery has a strong history of addressing matters related to the quality, patient care safety, and we are clearly concerned about the expanding the scope of practice in its current format. We also discussed briefly about the data earlier. There was comments made about the quality of care is almost comparable, those with the practice agreement, those without the practice agreement. I suspect the data is not clean. The American Medical Association in its own report coming out in 2017 does mention that there are 24 states where there is APRNs have a statutory authority to practice medicine without a physician collaboration, supervision, or oversight. The Center to Champion Nursing calls these as independent practice states, but it is not clear whether any APRNs are really practicing independently by themselves. In fact, the answer to this independent nursing practice question depends on whether the issue is more of a statutory one rather than an actual practice. In conversations with nearly about 40 nursing boards, it was not clear whether there is any record of APRN having practicing as solo practitioners. Only a handful of states even require APRNs to submit information regarding their place of employment, and none of them keep track of the number of independently practicing APRNs by themselves. In reviewing the actual practice of locations of U.S. primary care physicians, compared to the APRN, it is clear that the physicians and the APRN practice in the same large urban areas. This is true even for those states where there has been independent APRN practices without collaboration and they have not been able to address the shortage of physicians. I do not think this bill will address the ongoing issue of shortage of physicians in the rural practice. We have also earlier heard that the medical malpractice insurance can become an issue, as unlike the current existing structure, we are working in a collaborative fashion, and taking away that collaboration probably would mean a lot more cost associated with the medical malpractice as well. So in summary, I would like to say that the bill, SB 394 in its current format, will not only lead to the confusion delivering the care, and perhaps it may not address the access, and also adds to the risk of unnecessary cost and confusion for the patients. I'll be happy to take questions. Thank you.
Thank you, Doctor. Senator Brown.
Thank you very much. I think I heard, thank you very much. I know you're trying to go quickly. Did you say that unlike MDs and DOs, there's no national, the APRN training is different state to state?
At least that is my understanding.
Okay.
Yeah.
All right, thank you. And then I should have asked this of other physicians. I mean, I've had anecdotal stories. But is there anything as a surgeon that gives you pause, of someone, a nurse, APRN you're collaborating with now, that would give you pause if they were out on their own making this decision, making this, whatever, this medical treatment? Because I didn't want to correct her, but we had a witness a couple of witnesses ago in favor who said that as long as, with respect, for example, to prescriptive authority, that no one willy-nilly prescribes opioids, which I appreciate, but this very committee has heard testimony for years that the prescription pad, and mostly the blame was pointed at physicians for over-prescribing opioids, for a variety of reasons, which we have now clamped down on, and physicians have also changed their protocols. So, with that in mind, I don't think that was necessarily accurate, but if that were the case in the past, those APRNs had oversight. So that would have fallen if they were overprescribing. That won't be the case. But as an aside, that's a footnote. What sorts of things would you be concerned about that an APRN would be doing without having any oversight?
Well, I do hear the arguments, physician shortage in the rural communities, as well as able to provide the primary care services to the community at large. But I think expanding the practice to involve subspecialties, in the current format, I think if I look at the bill, it does mention anybody who has worked with a physician for a 1-year period, they can go and divest themselves into expanding themselves into the respective area of practice. Does it mean, as we talked earlier, somebody can go ahead and diagnose a melanoma, or somebody can go ahead and do a biopsy, and somebody can go ahead and do a sclerotherapy of a vein, or simple vascular procedures? So those are some of the concerns I do have with this current existing format. But I recognize the role of the APRNs. They have really worked well in the collaborative fashion. They are an integral part of my team. I do have APRNs working with me. Every patient the APRN would see, I would go ahead and see the patient along with the individual. From a documentation purposes, I do get help from a transcription point of view. And they do fill in my clinic schedule in a way that I can actually see more patients in that collaborative fashion, rather than just relegating it, because most of the times what happens is that would bounce back on my plate again, saying that what is your decision, what do you want to do here? And this is the CT scan, that how we like to interpret. So there are challenges associated with cutting loose somebody soon after their nursing school, having 2 years of training program, which is not standardized yet across the country. And more than anything, I would say just taking them away into the practice about a year into, I think I would be scared about it.
Thank you, Doctor.
Thank you, sir.
Dr. Jamie Stelzer.
Mr. Chairman, members of the committee, thank you for the time to talk with you today. My name is Jamie Stelzer, and I'm a pediatrician in Anderson. I'm here today as a member and representative of the Indiana chapter of the American Academy of Pediatrics to oppose Senate Bill 394. We have heard from lots about the differences between medical training and nurse practitioner training. As a pediatrician in a non-urban community, I not only admire my nurse practitioner, I need her. There's no question advanced practice nurses have a vital role in our healthcare teams for our Hoosier families with proper oversight and can extend access to care in our state. The concern we have as pediatricians is not the need for and the value of nurse practitioners, but the training and the number of clinical hours required to graduate with an advanced practice nursing degree. Again, I'm not going to go into the differences between medical student training, the 12,000 hours, and then the potential 500 to 750 hours for advanced practice nurse. I get requests monthly from Indiana Wesleyan University to be preceptors. To obtain an advanced practice degree, one must first be a registered nurse, then spend approximately 50 hours in an online coursework setting before moving on to clinical hours. Currently, these students in the state of Indiana are required to find their own preceptors, either physicians or advanced practice nurses, to complete their required clinical training hours. For pediatrics, a student is required to have 150 pediatric encounters to graduate with a Master's of Nursing Family Nurse Practitioner degree, again from Indiana Wesleyan University. I know this requirement because I get requests monthly to be a preceptor in pediatrics. These 150 pediatric encounters do not give these providers sufficient training to provide safe, quality health care without a collaborative relationship with a physician. To give you some perspective, 150 pediatric encounters I see in 2 weeks. Pediatrics, 2 weeks of education, it's not sufficient. We do residency for 3 years. In pediatrics, it's also seasonality, meaning that in flu season is going to be different pathology, different organisms that we see than in the summer. Someone had asked previously during a testimony who signs off on these students when they come to preceptorship. Having students in our office as a precepting office, a lot of the nursing schools have hired preceptors to sign off on these students. We can give our input, but we have no say whether they graduate or not. We need advanced practice nurses to help us care for all of our Hoosier families. Our hope is that the committee will see the importance of delivering quality and safe care to our families and why 1 year collaborative agreement with a physician after 150 pediatric encounters, 2 weeks, would not ensure this quality. I appreciate the opportunity to talk. I'll take any questions.
Thank you for your testimony, Doctor. I appreciate it. Dr. Feldman.
Thank you, Chairman Charbonneau and members of the committee. Thank you for the privilege to speak. I'm a family physician, former Indiana State Health Commissioner, and I represent the Indiana Academy of Family Physicians as their chair of legislative and governmental affairs. The IAFP is opposed to independent APRN practice, but clearly considers APRNs valuable colleagues and value their participation and relationships with physicians. We have long believed, as does the wider medical community, they are an important part of our healthcare team, led by a physician. And the two very well-respected physicians who testified in favor of this bill gave a very specific scenario. In their world, they're working shoulder to shoulder with nurse practitioners in their offices and their hospitals. And there is a free exchange of communication, of expertise, of questioning, and consultation. And in that environment, you don't need 5%. You don't need any chart audit review because you're working real time. And that's that team care led by a physician. As State Health Commissioner, I actively supported the creation and maintenance of nurse-managed clinics in underserved areas of the state. They work quite well with collaboration agreements with physicians, and it works today. I take no pleasure in being here today to oppose independent practice, but I feel compelled to do so. For the medical community, this is truly not about turf or competition, but quality and safety of care. There are certainly many talented and capable APRNs, especially those who have practiced for many years. But any physician who has trained or worked with a nurse practitioner knows that they have limitations due to limited training and experience. As a residency director for the past almost 38 years, I have trained not only family medicine residents, but medical students, APRNs, and PAs. And there is a huge difference in the knowledge, experience, and training between a physician and an APRN, especially as a new graduate. The central issue here is the quantitative as well as qualitative aspects to training in pharmacology and clinical medicine. Training is far from equivalent. You have heard the disparity in training hours while in school and for physician in residency. APRNs, 500 to 1,000 hours for a physician, 12 to 16,000 hours. And their training appears to be inconsistent with pathways and clinical exposure varying from state to state and school to school. But very importantly is the qualitative difference in training for a physician that involves intensive experiences, depth of responsibility, intervention, and years of direct, shoulder-to-shoulder, on-site supervision and oversight by faculty through the clinical years of medical school and residency. 5% chart audits, known as collaboration, is not equivalent or a substitution for supervision, direct teaching, and mentoring. Don't confuse the two. Patients come to a physician or an APRN undifferentiated. Chest pain could be a heart attack, a dissecting aortic aneurysm, or simple indigestion. Back pain could be a lumbar disc or a kidney stone, but it also could be a leaking aortic aneurysm or prostate cancer. APRNs need to be prepared to encounter all such clinical situations. There is a danger in not recognizing what one does not know through inadequate training and experience. There will always be the subtleties and complexities that demand a physician's clinical experience and judgment. APRNs claim that if they're faced with more severe or serious disease beyond their capabilities, they would naturally refer those to a facility or physician for care. I'm sure they would, but they have to reliably recognize that situation first. I doubt that any of you would want to go to a physician who graduated medical school and went out into independent practice after completing 1 year of collaboration agreement for a 5% chart audit. Potentially at a distant site from the supervising practitioner as suggested by this bill. I hope the same would be true for seeing an APRN in independent practice. As a residency director, I can attest to the readiness and competence of a resident for independent practice after 3 years of intensive, direct, on-site supervision, and actually must attest in writing to that to the accreditation body before they can graduate residency. Having said this, the Indiana Academy of Family Physicians has made it clear they're willing to compromise with APRNs in their pursuit of independent practice. We do not believe that the requirement of 1 year or 3 years of a chart audit collaboration contained in this bill can assure the readiness or competence for independent practice. We also need to be very careful about how we define 1 year. In my world, it would be 2,000 to 3,000 hours a year. The compromise position of the Indiana Academy of Family Physicians offered last session and rejected is still our policy and position. It is that if the APRN desires independent practice, the APRN would work directly for 3 years with a physician or in a licensed facility with direct, on-site, shoulder-to-shoulder supervision. I'll point out that Ty Morrell, the nurse practitioner from Rushville, would, because she worked with her father for 3 years, would have qualified for independent practice given this paradigm. We also want to be sure once they are independent that they have a patient transfer agreement to a physician or health care facility for more complicated patients. APRNs are very worthy professionals, essential to patient care, but they're not physicians. We also have some other concerns with this bill. That oversight, since this is the practice of medicine, is not with the Medical Licensing Board, or at least in collaboration with the board. That the collaborating practitioner does not have to be a physician, and that the APRN certified and licensed in a specialty and obtains the required collaboration can certify in another specialty and does not have to have another collaboration period of a requirement for that additional field. I want to be clear that the Indiana Academy of Family Physicians, for us, it's not so much about opposing independent practice. It's providing adequate training and experience before independent practice. We stand opposed. I would like just to close with a short quote from a family physician who was previously a nurse practitioner. I didn't know what I didn't know until I went through 7 more years of training, says family physician LaDonna Schmidt of Salina, Kansas. Schmidt was a nurse practitioner before she did further training to become a physician. Schmidt noted that she had thought her further training to become a doctor would be easy because she had already gone through training as a nurse practitioner. It wasn't until she got into the program that she realized how much she did not know. And that's our fear. Thank you.
Thank you, Dr. Feldman, for your testimony. I appreciate it. No questions. We have two more that have signed up to testify. Lori Sanford.
Hello.
Welcome.
Thanks. So, Chairman and fellow committee members, my name is Dr. Lori Sanford. I am a board-certified dermatologist. I practice in Hancock County, Greenfield, Indiana, and serve the surrounding rural areas. I am here as a member of the Indiana Academy of Dermatology today, and I represent 120 dermatologists across the state of Indiana. The Indiana Academy of Dermatology is opposed to passing this legislation because of the removal of the requirement of the 5% supervision of the nurse practitioners. This moves away from the goal of delivering health care in a coordinated, cost-effective manner with physicians as our team leaders. Removing this collaborative agreement between a nurse and a physician severs those ties in many ways. And I've actually crossed off about 7 paragraphs here because I think everybody has addressed a lot of our testimony today. But I want to give you a little bit of firsthand experience in my world. So I think that nurse practitioners are very valuable healthcare providers. I myself have an intelligent and very caring nurse practitioner in my dermatology practice. We collaborate on a daily basis. Our desks are adjacent to each other, and I contribute to whether she biopsies things, how she prescribes, and that's all done. My collaboration is done prior to patient care. If she's seeing patients, I'm immediately available to weigh in on diagnoses and to assist in any procedures that she's not adequately trained to perform. This is a really good, safe model for patients that expands access to care. As the only board-certified dermatologist in Hancock County, it was really important to me to have someone available to help. But Gina and herself really appreciates my guidance. She's been practicing for 3 years, and she continues to utilize my training and extra education to help her care for patients better. She's invaluable to my team and my patients, but she's most certainly not a dermatologist. This legislation would allow her to separate from me, and she could start her own practice. She is a family nurse practitioner, but she has experience in dermatology, but I'm not certain that would be a safe thing to happen. So I do think that it's important to understand the difference in supervision and a physician in clinical training versus our 5% collaboration. A 1 year internal medicine that I did as my first year residency was 100% supervised. That's very different than 5%. And while Gina's training has been much more than that 5%. Removing this legislation removes that one bit of oversight that helps us to help them and take better care of our patients. Allowing nurse practitioners to practice independently affords nurses the same authority and clinical autonomy that physicians have, and there's nothing to prevent them from practicing specialties, so especially in outpatient care. So we're very concerned about Senate Bill 394. We don't want this to undermine the delivery of quality patient care for Indiana patients. And for these reasons, the Indiana Academy of Dermatology urges members of the Senate Health Committee and Provider Services Committee to oppose Senate Bill 394.
Thank you, Doctor. Senator Lysing.
Since the majority of the opposition emails that I received were from dermatologists, which I found really interesting since you're few in number, really, statewide. Is it that you're fearful that if this bill passed and the advanced practice nurse would identify some issue on her patient's skin, that she would in turn ignore it or not refer them to you? She wouldn't be able to remove it, right?
Many do, and there are.
You're saying they can?
They can. So, for instance, a shave or punch biopsy is something that many family physicians or extended providers do, but it does create circumstances for misdiagnosis. If someone freezes a melanoma, that's a problem. A punch biopsy for a melanoma may require I do an excision over a simple scrape and burn procedure, so increases patients' risk of infection and bleeding. A much more significant procedure.
So are you saying that if somebody expects they have a dermatology issue, they should not go to a family practice doctor either?
No.
Because they would do that same kind of process, probably?
No, but family practice doctors are board certified in family medicine, and they practice family medicine. My instance was a family nurse practitioner may be able to open a dermatology practice on their own. They could. There's no truth in advertising in this bill. Someone could open an outpatient clinic and say I'm a family nurse practitioner who specializes in dermatology care. And then they would be.
And you're saying their skill to diagnose would be limited to a scraping? If a patient came in with a problem,
what I'm saying
they're
is
limited in not being able to diagnose.
They're not trained with 3 years of clinical dermatology to be doing a lot of those
But
things.
if there was a problem that showed up in their testing, they would be referring, right?
Maybe.
And why wouldn't they refer?
I'm not sure. Maybe they don't have insight to know that they're doing something incorrectly, and that's been the case in some patients I have seen.
Okay.
Senator Brown.
Thank you, Mr. Chairman. I just want to clarify. I think I heard what you said is a couple of things. With reference to a family physician, I think the idea is not knowing what you don't know. I think that what we're understanding is a family physician understands that they're not a dermatologist. So if there are issues with respect to possible basal cell carcinoma, melanoma, or something, or some contact dermatitis that turns out to be something totally different, they know enough to know what they can treat and not treat. My concern is, I think what you said, I heard you say, is in terms of, quote, testing, scraping, is being a fair-haired, blue-eyed person. I've actually had some experience with some of these issues, is that you really have to be very careful in actually diagnosing it and testing it. Mm-hmm. It isn't so much like maybe you can, I think you said freeze a melanoma. Mm-hmm. Right, do something inappropriate that actually botches the test, but you can also misunderstand the severity. And quite frankly, in your specialty, melanoma is devastating. And so sometimes, having had some relatives die of this, the misdiagnosis or missing that one mole is devastating, and not understanding that you don't know what you don't know, I think, is what you were trying to.
Yes, thank you, Senator Brown.
One last question.
Sure.
Is it your opinion that right now that an advanced practice nurse should never be able to get out from under the collaborative agreement?
It's difficult, but I think that we have to really look at the comparability of training before consideration of independent practice. And, a residency is 4 years of 100% supervision versus much shorter periods of time.
So the answer is no.
The answer is at this time.
Okay. Doctors, thank you for your testimony. I appreciate it. Last one, and I apologize, Cheryl Ferguson. The fact of your last means nothing other than you went to the end of the stack.
No, I'll try to be brief because I think
Thank
Dr.
you.
Feldman hit a lot of
Thank
my
you.
points. My name is Dr. Cheryl Ferguson. I am a pediatrician in Fishers, Indiana. I graduated from nursing school at the University of Evansville in 1983. I went back to school and I graduated from the Indiana University School of Medicine in 1994. I finished my 3-year residency in pediatrics at Riley Hospital for Children in 1997. I've been a pediatrician for 22 years and I've been a Hoosier all my life. I really don't want to be here. I canceled all my morning appointments. I've got to get back this afternoon. I am close to retirement. This is really not about my job. This is about safe medical care in Indiana. Nursing is not medicine. I have practiced both. I had to take 40 hours of physics, biology, chemistry, and organic chemistry just to take the MCAT and apply to medical school. My nursing science courses in nursing school were not high enough level. Nurses are trained in psychology and sociology and health. It is much needed and noble profession, but it is not the same as medicine. I think it is a shame that nurses are being encouraged to leave bedside nursing to practice medicine without going to medical school. This is contributing to the nursing shortage. There's every nurse you talk to, they're working on their NP, their NP. The online NP diploma schools are popping up overnight. This concerns me more than anything. I don't have as much trouble with people going to IU or Purdue or Ball State, but these online programs, 18 months online, that's 100% acceptance rates. That means no one's vetted. If you can pay the bill, you can get your online NP in 18 months. I don't see how the AANP can demand unsupervised practice for any and all NPs when they're really not the same. There are people that have 20 years of nursing experience, but there are people that have none. Vanderbilt has a program where you can have a bachelor's degree in anything, elementary education, and apply to the Bridge program and get your NP in 2 years. And that's it. I mean, it's crazy. I have had patients go to urgent care. I had one patient went to urgent care and was told he might have diabetes because he had ketones in his urine, which most physicians would know is not diagnostic. And the same patient went to the ER that night, saw another NP, was told he might have cancer. He came to see me the next day. I sent him to Riley where he had a CT scan. He had pneumonia. I told his mom he didn't have cancer. Lung cancer in kids is rare, and one little spot on his lung is 99% of chance is pneumonia. And the child psychiatrists, there are so many NPs practicing child psychiatry, it's quite scary. They're getting lots of powerful psychotropic medications, and I don't know what that means in the long run. Let's see, I'm trying to skip over what Dr. Feldman already said. Most of the studies that NPs provide that said they have equivalent care have been proven to be poor methodology, and I've got the research that covered that. Oftentimes NPs cost more because they order more tests and more x-rays and more labs because they're not sure independently what's going on with the patient. They just don't have the experience and the training. Let's see. There are some, I have never felt overtrained. There are some NPs that say that we've been overtrained, but often an unexpected problem can present as something quite simple until you ask the right questions and do a complete physical exam. It takes years of training and practice, and you have to have another doctor show you how to do it right and what you're doing wrong. I think that's about all I did, and I'm skipping over things that have already been said. I just want to say Indiana has always been a great state to practice medicine, thanks to Dr. Otis Bowen, who was governor for many years. We've provided excellent health care to Hoosiers. Indiana needs to increase their family practice residencies and increase the physicians in the rural areas and not substitute physicians with nurse practitioners. Thank you.
Thank you, Doctor. I appreciate your brevity. And
Thanks.
Senator Brown?
Thank you very much. That was some of the most insightful information that anyone's given us. I mean, what I think what we're doing here today is trying to get access to care, but we're coupling it and confusing it with better care. And so I think that's what we really need to understand here today. What we're trying to get is more people who don't have access to care, perhaps. That's the intent here. But when we talk about things like prescribing psychotropic drugs to children, diagnosing things outside your scope after you have an online degree, and perhaps increasing the opioid crisis, because no one has suggested that their scope should be narrowed or that their prescriptive authority should be narrowed if in case they haven't had all this training. It's just going to be a free-for-all. So I really appreciate that you're willing to do that. I know it's very difficult because most physician practices and hospital practices have APRNs, nurse practitioners, and PAs, and they do a great job. But they're not independent, and you're actually in the most collaborative environment you can be. But now we're talking about putting them out there in solo settings with no oversight. So thank you very much for that.
Thank you.
Doctor, I'll ask a question that I asked Dr. Sanford. Do you believe that there should be a way for the advanced practice nurses to get out from the collaborative agreement?
Not in family practice. I think they have a role with specialists to help see patients that might be there for follow-up. I think they have a great role for education. But I don't think they should be independent of another physician. I think one family practice doctor and 2 nurse practitioners could be a wonderful setup for the rural areas, but I don't think they should be independent of it and have no physician close by.
Collaborative agreement. How does that happen?
I have never had a collaborative agreement with a nurse practitioner, so I'm not an expert on how that all works. I have seen a lot of my patients see nurse practitioners in urgent cares that aren't closely collaborative. I think they should be a little closer. You need to review at least, I would think, 50% of the charts. 5% I think is just kind of a drop in the bucket. And I think it's nice if you could be someone you know very well. My sister is a nurse practitioner. She works in the endocrinology department at Vanderbilt, does all the diabetic education, is very close with the endocrinologist. I think that's a perfect setup. I think there are places for them. I just don't think it's an independent clinic by yourself in the country. That's
I
a scary
think
place.
The term collaborative agreement is the wrong term to be using when you're after the fact looking at 5% of someone's charts. There really isn't any collaboration going on.
I agree.
And are you aware of, under this current situation, any problems?
Yes. I've seen lots of problems with things that they were talking about of just not
what other people are talking about. Are you aware?
Have I seen patients Yes, I've seen patients come into my office that are put on the wrong antibiotic, or I've had people told, like I described the one child who was told he had diabetes, then he was told he had cancer. They're misdiagnosed, or one kid had strep throat, nobody looked in his mouth. I mean, simple things. I've had 2 kids that had ruptured eardrum that was put on antibiotics because they didn't know what a ruptured eardrum looked like. They thought he had an ear infection. Like, ear pain is antibiotics. It's not always antibiotics.
And those were treatments by advanced practice nurses.
Yes.
Did you do anything after that?
The children with the ruptured eardrum, I sent them to the ear, nose, and throat doctor.
With the advanced practice nurse.
Did I do anything? I'd contacted them and mentioned, well, I contacted the urgent cares where they worked. What happened after that, I don't know.
Okay. Thank you for your test. Concludes the testimony. As I said at the beginning, I hope I said that I am still maybe just totally a pipe dream, but I would hope that there is a way that we can resolve this situation to not everybody's complete satisfaction, but to protect interests that we've heard a lot of concern about today, but still move the ball forward. Whether or not that's possible, I don't know. So at this point, we're just going to hold the bill. We'll take a vote and see what happens. So with that, we are adjourned. Thank you.
So next week.